Hi, everybody. My name's Casey Gordon. I am going to say sorry for my voice this week. I tried to wait it out, but I am just getting over a illness, so bear with me. I will be presenting on the pharmacological management of an 18-year-old female with major depressive disorder. I'm going to tell you about why I chose sertraline, what the pharmacology behind that is, what second line therapy I chose, um, the prescriptions and how I would prescribe them, and then what monitoring and patient education I would use for that patient. First line treatment would be sertraline, which is a selective serotonin reuptake inhibitor. Our patient is an 18-year-old female in her first year of college with no significant medical history or history of substance abuse. She is showing moderate to severe major depressive disorder, or MDD, symptoms. Her symptoms have lasted for longer than 6 months, and she is showing thoughts of death consistently. That is what's leading us to follow the guidelines and follow through with treatment of an SSRI at this point. Sertraline is an SSRI. It blocks the serotonin transporter, SERT. More serotonin remains in the synapse. Greater stimulation of postsynaptic receptors occurs. As you can see in the photo here included on the slide, that means mood improves gradually, and improvement is not immediate. I like to stress this point here because it makes patient education so important. Patients often think the medication isn't working after only a few days. However, the neurotransmitters need to build up in order for the patients to be able to feel the effects. So it takes about 2 to 4 weeks in order for that to happen. This drug has antidepressant effects, improves anxiety as well as treating the MDD. It takes several weeks because receptors adapt over time. That's why I chose to put the clock on this page, to drive home that fact that it's going to take several weeks to kick in. It is well absorbed. The liver metabolizes this medication. It is often or most likely given once daily because of the 26-hour half-life. If sertraline is ineffective or poorly tolerated, another option would be bupropion or Wellbutrin. Bupropion belongs to a different drug class. It is a NDRI, which increases dopamine and norepinephrine. It has minimal serotonin activity, which is helpful if the patient was suffering from sexual dysfunction, fatigue, and wants to avoid any weight gain. Obviously, you would avoid it in patients with any seizure history, eating disorders, or alcohol withdrawal. However, SARA, bupropion, is a good second-line medication. According to the guidelines, SARA already has insomnia and weight loss, making this a less attractive initial treatment for her. Bupropion is more activating of a medication. It improves energy and motivation, and can initially worsen insomnia and anxiety. It metabolizes through the liver. I put the weightlifter on this page in order to show that it's a more activating medication. I find that pictures often help me remember things. I also put the fact that she's already suffering from insomnia and anxiety. So I put that picture on here as well. However, many patients find that this temporary activating effect is preferable to any persistent SSRI-associated fatigue or sexual dysfunction. The half-life for this NDRI ranges depending upon which kind of drug is being used. The parent drug is about 21 hours, where the extended release it supports once daily dosing, where the sustained release is typically dosed twice a day. The prescription I would write for this patient would be to start at 25 milligrams a day and increase after 1 week to a therapeutic dose of 50 milligrams daily with no refills initially, and then she'd come in for her follow-up before long-term prescriptions are filled. Starting low improves tolerability and reduces early GI side effects. This is what the prescription that I would fill out would look like. There are several interactions with other medications. In sertraline, you should not take any MAOIs, any serotonergic medications, any NSAIDs could cause an increase in bleeding. Alcohol also could intensify the effects of sertraline. There are several adverse effects as well. Most commonly noted are nausea, diarrhea, insomnia, and sexual dysfunction. Serious adverse effects are serotonin syndrome, suicidal ideation, and hyponatremia. Therefore, routine sodium levels should be tested. Patients should be monitored for suicidal ideations with a pH 9. And serotonin syndrome should be monitored for as well. At baseline, you're going to test the PHQ-9, as well as then repeat it during weeks 1 and 2, and then again during weeks 4 and 8, just to ensure patient safety. You're also going to continue doing suicide assessments. You want to do weight and sleep assessments during your baseline assessment. During weeks 1 and 2, again, doing another suicide assessment and adherence to medications. And then during weeks 4 through 8 is a good time to decide whether or not to increase the dose or change therapy, because you've given the medication a long enough time to see if it is working for the patient or if it's causing any side effects that they are not able to cope with. There are so many non-pharmacologic treatments. Medication alone is not enough, and that should be emphasized, especially for an 18-year-old female. Developing coping skills. Cognitive behavioral therapy is amongst those discussed within the guidelines. Interpersonal therapies, exercise, sleep hygiene, counseling, family and social support. The clinical pearl here is that medication plus psychotherapy produces the best outcomes, and that is written right within the guidelines. The big takeaways for patient education, this is exactly what I would tell Sarah, is that you have to take this medication every day, take it at the same time every day, Don't stop it abruptly, and don't stop it without talking to your doctor first. It may take up to several weeks before you can see any of the effects. Please continue with your therapy of whatever kind that may be, CBT or otherwise. Watch for worsening of your suicidal ideation. Avoid any alcohol because will only intensify effects. And call if your symptoms worsen. You can mention the FDA boxed warning given her age, but I think driving home these patient education points, I think you would be in good shape. Also, answering any questions that she has and developing a good rapport with her will only benefit her in the future and your relationship moving forward. Thank you so much for listening to my presentation. I apologize again for my voice, and I greatly appreciate you sticking through the entire thing. These are the references I use, the guidelines, the rest of my sources, and I hope you enjoyed it. And let me know if you have any questions. Thank you so much. I look forward to working with you guys this week.